Okay, great. So hi, everyone. Thank you so much for joining us today. Welcome to our very first session of the Research Seminar Series. My name is Maria, and I am a Program Assistant with the BC Brain Wellness Program, and I'm very excited to be hosting today's session. We have two amazing speakers today, Caitlin and Rhiannon, who will be talking to us about what dementia is, some risk factors, and also an opportunity to get involved in a study. Since this is a brand new program of ours, I just wanted to give a bit of a background to this monthly series of ours. The Research Seminar Series will be happening once a month, and we will be featuring some of the amazing researchers here at UBC that are working on research related to brain wellness. We want to bring some light to the incredible research that goes on that can have the impact to improve healthcare and can also be a way to empower people in their own health and brain wellness. Participating in research can also be a way to learn more, which is why we will be spotlighting some of these studies that you are able to participate in. Before we dive into the session, I just wanted to first acknowledge that the BC Brain Wellness Program at the Dajabad Moafagian Center for Brain Health is situated on the traditional, ancestral, and unceded territory of the Hunkaminam-speaking Musqueam peoples. I am joining from UBC and would like to invite you all to take a moment to acknowledge the land that you are joining us from today. There are also a few housekeeping items just to keep in mind. If you have any questions or your thoughts that pop up throughout the session, please feel free to send them in the chat box and we will be getting around to them during our Q&A session. Please note that we are recording today's session and we'll be uploading it to our YouTube channel. Without further ado, I would like to introduce our two speakers, Caitlin and Rhiannon. Sorry, one second. Caitlin comes from an undergraduate background in linguistics and psychology from the University of Calgary. Caitlin has worked in academic research labs, examining early language development and the role of physical activity in preventing neurodegeneration with a geriatric population. Following graduation, Caitlin spent a year working in a clinical setting as a cognitive therapist for acquired traumatic brain injury patients. After a recent move to Vancouver, Caitlin started working as a clinical research assistant with the Vancouver Stroke Program and began working on the CANARY study, among other research projects. Rhiannon Cho is a research assistant with CANARY and is a science co-op student at UBC, currently studying neuroscience and physiology. He enjoys his role in clinical research and as it allows him the opportunity to develop a healthy relationship with patients and contributes to a unique perspective on approaching neurodegenerative conditions. He hopes to work in the medical field in the future and is inspired by the potential advancements in medicine arising from the interface between novel machine learning and standard clinical practice. And now I will pass it on to Caitlin and Rhiannon.
Thank you, Maria, for that very kind introduction, and welcome everyone to this research seminar series on dementia, risk factors, and artificial intelligence. So we will be discussing a scientific review of what dementia is, who is at risk, and what we as researchers on the CANARY project are doing to help identify those who are at risk earlier. So although Rhiannon and myself are presenting our research today on behalf of our team, I would also like to mention our computer science team, which is composed of experts in natural language processing and machine learning at UBC, and they are critical to designing the machine learning framework for our CANARY project. So we will break this research seminar into two sections. The first half of the presentation will provide an overview on current dementia research and why identifying as well as intervening on earlier risk factors can help improve patient outcomes. The second half of the workshop, we will introduce our study, the CANARY project, which is aiming to fill the current gap in identifying individuals who are at risk for Alzheimer's at the earliest stage of the disease using a non-invasive approach based on speech and eye gaze patterns and artificial intelligence. So let's start with a key question. What is dementia? So dementia is an umbrella term for several diseases that cause a loss of memory or other thinking abilities. For example, dementia can cause a decline in memory, language, problem solving, or other cognitive processes. It can affect a person's everyday ability to do their daily activities. The most common form of dementia is Alzheimer's disease, or AD, which makes up about 60 to 80% of all cases of dementia. Alzheimer's disease, or AD, is thought to be caused by the formation of abnormal deposits of protein in the brain called amyloid plaques and tau tangles. Plaques and tangles are both present in healthy brains, but they appear in Alzheimer's disease in much higher quantities than normal, and they work together to damage the brain cells and cause them to die. It is due to these plaques and tangles that we start to see changes in the speech and eye gaze patterns of those who have neurodegenerative disease. Once enough cells die, the brain actually begins to shrink, and the areas of the brain responsible for memory and other cognitive processes start to diminish, and the typical clinical symptoms of dementia patients start to appear.
So to characterize dementia in figures and statistics, according to the World Health Organization, approximately 55 million people have some form of dementia. And of that population, about 33 million have Alzheimer's disease. When considering the amount of people that account for this demographic, it is pretty much comparable to the population of Canada. And this rounds to a little over 1 in 9 people, or 11.3%, aged 65 and older having Alzheimer's disease. So that amount of people with dementia comes at a high global cost, as you can imagine. The global cost was estimated to be as high as $818 billion US in 2015. And that number has only risen since that time, along with the amount of people diagnosed with dementia. So this global cost is attributed to individuals retiring early, family members or friends providing unpaid care, and the costs of medical care itself, such as nursing home staff, medications, and physicians. And also, of course, aside from the financial cost of dementia, there's an immense emotional impact that accompanies this classification of diseases. Because it is a chronic condition, dementia often has a long-lasting effect to not only patients, but also family and close peers. Losing sense of self and identity, memory, and physical function can frustrate patients, and especially so if they are self-aware that these changes are occurring. Along with the stress that the patients undergo, there's also a huge burden on the individuals whom support the patients during these changes.
So what is important to Alzheimer's is understanding your risk factors. So here we want to break down these risk factors into 2 categories, either modifiable or non-modifiable. A modifiable risk factor means that you have some control over changing your risk, whereas non-modifiable means it is not changeable. As you can see, 3 of these factors are not in our control: genetics, age, and sex. Genetics can play a determining role in your risk for developing Alzheimer's, but only 5% of all cases of Alzheimer's result from a gene that has a high likelihood of being passed on through families. The majority of genetic risk associated with Alzheimer's later in life are likely due to small contributions from several genes, plus environmental factors, so things like diet, pollution, exercise, and social factors like poverty, education, and social interactions. Additionally, although age is listed here as a risk factor because prevalence of AD increases with age, aging itself is not a guarantee of getting Alzheimer's disease. As for sex differences, females are more likely to develop dementia, but this differs among different types of dementia, and it is a small difference. So the key takeaway here is that even for individuals who have non-modifiable risk factors, your environment also plays a big role in determining whether or not you will develop AD. And you can continue to work on reducing your modifiable risk factors throughout the lifespan. So reducing things like low HDL cholesterol, high blood pressure, obesity, high blood sugar, smoking, getting better sleep, and pursuing more education all contribute to decreasing your risk of developing dementia. And of course, when talking about these risk factors, it's important to know how scientists study risk factors. Many of these were found by looking at very large groups of people that represent a population. Since they have been studied on a population level, they do not necessarily translate into recommendations for a single person. Risk factors are not the causes of the disease, but rather they represent an increased chance, but not certainty, that dementia could develop. Similarly, Having a few risk factors does not mean you will not go on to develop AD. It simply means that you may have a reduced risk. Other public health experts, such as Dr. Carol Brain, one of the world's leading researchers on dementia, concluded that in brain aging, 1/3 to 1/2 of all dementia could be prevented or delayed if people address their modifiable risk factors within their lifespan.
So current research supports evidence that intervening on risk factors can improve outcomes. For example, in a recent 2-year study in 2015 conducted on individuals aged 60 to 80, multiple risk factors such as diet, exercise, cognitive training, and vascular risk monitoring were addressed. So this study was published in Finland, and they followed both national and international guidelines in terms of conventional health approaches. So for diet, diet was regulated according to individual and group counseling with a special emphasis on both fruits and vegetables, fish, and whole grain. Exercise interventions included aerobic and balance exercises at the gym, and the intensity of these workouts were increased throughout the intervention period. There was also cognitive training and skills such as episodic memory, processing speed, and executive function. And while it was a very comprehensive intervention study, results found that these interventions were able to slow cognitive decline by about 20%. So this is one of the first studies looking at multiple risk factors and approaching them with a multi-domain lifestyle intervention rather than focusing on just a single risk factor. And so a key takeaway from this study in particular, as compared to those that only addressed individual risk factors, is that patients should pay attention to all factors that increase your risk. And there does not appear to be strong evidence that isolating a single risk factor and addressing it alone can change the rate of cognitive decline, but rather the additive and combined impact of intervening on multiple risk factors can improve outcomes. So for example, having healthy exercise habits without a good diet may not create a significant impact on outcomes. You would need to intervene on multiple risk factors at the same time for positive outcomes.
And as for current treatments, this diagram shows all of the drugs that are currently in clinical trials for Alzheimer's disease in 2021. And as you can see, there is a lot of ongoing drug trials currently happening to try and improve patient outcomes, either through symptom-reducing drugs or disease-modifying drugs. The part I want to draw your attention to on this graph is the disease-modifying section, or these are the drugs that will stop or prevent further neurodegeneration from happening. And these trials are primarily looking for participants who are in the preclinical stage or cognitively normal, but known to be at risk for developing later Alzheimer's. A continued challenge for these trials is the slow rate of recruitment. So the amount of time that is required to find eligible patients to participate in their study is longer than the treatment period in nearly all of these trials. And there has been no trend towards shortening these recruitment periods over the last 5 years. So in order to speed up the pipeline of getting a drug approved that we can potentially stop the plaques and tangles from forming, we need a brief, cost-effective screening tool that can be administered to a widespread population and can identify individuals in the earliest stages of the disease.
So currently, most medications for Alzheimer's disease only help with the symptoms that result from dementia and do not reverse or change the course of the decline during this time period. And so although there's one drug called Aduhelm, which some of you may have heard of, that reduces amyloid plaques, its FDA approval was only in the US in 2021, and there is some controversy surrounding it due to limited evidence of efficacy in a subgroup and also high rates of serious complications as a consequence of using this treatment. On top of that, it costs over $56,000 for 1 year of treatment, which simply isn't financially sustainable for the vast majority of patients. Therefore, research of Alzheimer's with respect to early risk identification and intervention is crucial to potentially minimizing and delaying the onset of dementia, as well as supporting research for other sorts of novel treatment methods.
So I just want to take a quick break here and discuss any questions or comments that may have come up from the first half of our presentation before we move on to the second half about our research project. So was there anything that was unclear or you would want any further clarification on in terms of understanding risk factors and the current treatment options for dementia?
So I do see a chat response over here talking about social interaction also being a risk factor. As far as I know, that is indeed a risk factor. Social isolation is indeed a risk factor for developing one of these conditions. During that Finnish study that I cited earlier, where they identified and sort of intervened on multiple risk factors, social support and conversations between the participants and the healthcare staff that they worked with for the duration of the study. They did encourage social interaction, and then they, of course, checked in with these patients to see how they were doing socially, and also made them feel as if they were supported in whatever sort of changes they were going through or sort of interventions during the risk factor intervention period. So that is a good point to note. And that would be, of course, a modifiable risk factor. Interacting with individuals and versus social isolation would be something that you sort of have control over.
And then a second one from the chat here about the amyloid deposits. It definitely could be rather a correlation than causation. I believe a lot of the research has just been looking at comparing healthy brains versus Alzheimer's brains and seeing this increase. But again, we don't know the full relationship between it. And I think more advances in neuroimaging and identifying these people earlier can help us figure out that relationship, whether it is causative or it is just kind of a byproduct.
And then, is there an easy test for high blood sugar? As far as I know, I think a blood draw is the standard test for high blood sugar. I don't think there's any way for them to check it without grabbing a blood sample.
There's just a response from Silky Creswell here about the blood sugar. So this can be easily measured by either measuring blood sugars at the present time directly, your physician can order this, or the mean blood sugar over 3 months. HbA1c can be ordered by your physician, or you can now get even that in the pharmacy. And there's another question here about ginkgo biloba or other over-the-counter tablets. I'm not 100% sure about ginkgo biloba. I haven't read any research on it that has found anything over the counter has made a really big impact, but I will definitely look into it further and get back to you on that question.
Yep, so those medications that I discussed earlier that help treat the symptoms, those are administered through prescriptions as standard clinical practice. And so dosing for these treatments is also, it's up to the physician's prescriptions. And so sometimes patients have, I don't want to frighten you, but some patients do have some sort of psychiatric responses or adverse reactions. And so they generally start at a lower dosage. And then if it is tolerable and it is indeed helping these patients, sometimes they'll increase the dosage for the dementia medications.
And for the question about exercise, in the Finnish study Ranim was talking about, it was both balance and then low intensity exercises. Overall, exercise as a single risk factor addressing has not been able to really effectively reduce the rate of cognitive decline. But once you combine that with diet, with social interaction, with all of these other factors, then we start to see closer to that 20%.
And so to sort of address that point about amyloid plaques having some sort of protective effect instead of necessarily pathogenic, I believe Caitlin did say at that slide that it is normal for a brain to have these neurofibrillary tangles as well as these amyloid plaques. And so I would buy into that sort of idea that it does have some sort of protective effect. However, the problem is when they are present in excess, and that's sort of how they damage your brain and cause it to shrink when there's just too much of it. And so that would be the pathogenic side of having these amyloid plaques and tangles.
For the question, how do you find out if you are at risk for Alzheimer's? So if you are noticing any sort of cognitive symptoms, we do encourage you to go to your GP and get referred for further assessment. You can also volunteer to participate in our study, and we would refer you to our study doctor if there was anything abnormal that came out on our cognitive assessments. I feel like we've mostly addressed, or there has been responses addressing most of these questions in the chat, and the recording will be available.
As far as cognitive training, some easy to do ones. I'm not sure that it would be easy to do any that are administered by doctors or researchers, but I mean, even something as simple as a crossword puzzle or, playing Sudoku, that is sort of working on your cognition. And I think that it could help with your outcomes down the line. And yes, the recording will be available after the event.
For the question on if there's been any research on the use of music in treatment of dementia, from the preliminary research we did, I didn't see any significant findings from music, but I also agree with you, especially with dealing with the emotional impact of patients with dementia. I think music could be a very valuable tool. Okay, yeah, so maybe we'll move on to the second half of our presentation here, and then we can address some more of the Q&A questions at the end. We'll start talking about more of our research project and what we are doing to try and identify those who are at risk earlier.
And so although approximately 40% of dementia is attributed to modifiable risk factors throughout a person's lifespan, there are still roughly 60% of cases where the risk is unknown. And so as such, it's still important to find treatment in cases that, despite control of risk factors, cannot be prevented. To date, over 100 clinical trials of potential therapies to modify or stop the progression of Alzheimer's disease have failed. And a reason for this is because oftentimes the neurodegeneration is too advanced at the time of diagnosis to change the course of the decline. Furthermore, evidence shows that amyloid plaques and neurofibrillary tangles, the hallmarks of Alzheimer's disease, can be present 10 to 15 years before clinical symptoms occur. And so if there is a proper identification earlier on, there would be possibly an opportunity to intervene earlier for better patient outcomes. And although the drug Aduhelm, which we discussed earlier, has been shown to reduce amyloid plaques, the research on Aduhelm is still inconclusive about whether reducing amyloid plaques themselves can actually reverse or halt the cognitive decline. And then once again, it's extremely expensive, and a lot of the time there are many side effects to that treatment plan. So it's not the standard, but clinical trials are still sort of trying to see the efficacy of drugs that are similar to it. And so this means that it is still important to be able to identify individuals who do not yet have advanced neurodegeneration and those who are at risk of, or at high risk of developing Alzheimer's, because these individuals would be in a position to receive treatment where successful disease-modifying drugs for Alzheimer's would also be most likely to demonstrate an effect on their cognition. So with the status quo, it is very difficult to screen for individuals who do not yet have any clinical symptoms of Alzheimer's disease and are at high risk of developing further neurodegeneration later. So the current diagnostic framework involves many invasive and costly tests to search for brain abnormalities and detection of amyloid deposits. So typically, patients will approach their physician with some sort of chief complaint regarding their cognition, such as acute memory issues, inability to focus, or loss of motivation, or some people say they've lost enjoyment in doing their hobbies, or apathy. And so sometimes these patients are accompanied by a family member who will provide further context to any events that have recently occurred. And then the doctor would then perform some cognitive assessments for them. And if there is enough of an impression that it is indeed dementia being the cause, while accounting for the patient's whole medical history, radiographic imaging may be recorded, and both neurological and cognitive function tests may be administered down the line. And so oftentimes these are performed as a result of presented cognitive symptoms in a clinic, which indicates that neurodegeneration has likely already begun for these individuals. And so because of that, there is a demand for a quick, non-invasive, inexpensive, and scalable screening tool for classifying risk in the earliest stages of dementia.
So how can we determine risk early on and classify dementia early when no symptoms have occurred yet? This is where our research group CANARY aims to fill the gap. So to look at this question, we looked at previous research on speech and eye tracking, which found intriguing findings demonstrating the ability of speech and eye tracking to classify abnormal cognition and neurodegeneration before clinical symptoms appear. A study that examined the autobiographical writings of nuns in the United States in their 20s found that those who had a low idea density and low grammatical complexity in their writings were found to later have autopsy-proven Alzheimer's disease. A similar analysis was done on famous author Iris Murdoch's last book, which showed a deterioration of semantic skills and vocabulary richness, which was published a year before she presented with clinical symptoms and was diagnosed with Alzheimer's. So what does this look like in the brain? The neurofibrillary tangles and protein deposits we talked about earlier in the presentation cause neuronal death in Broca's area and the perisylvian region. These areas are responsible for both speech production and language interpretation in the brain. People with Alzheimer's have been shown to have impaired speech, resulting in increasing pausing and word-finding problems. They also demonstrate low grammatical complexity and limited vocabulary. So they often use non-specific words for their intended word, for example, saying he grabs the thing instead of the boy grabs the jacket.
In addition to the speech patterns we described, brain cell death and neurofibrillary tangles, as well as amyloid plaques, also affect the cells in the visual cortex. And so this leads to changes in vision, attention, and the way that the eyes move in patients with Alzheimer's. Specifically, patients have been found to have disrupted prosaccadic behavior, poor performance on anti-saccade tasks, slowed pupillary responses, and impaired smooth pursuit. So I know it's a bunch of technical terms, but these technical terms pretty much boil down to abnormal or disrupted movements towards and away from a target, and also struggling to follow a moving target smoothly. And so sometimes a patient may not be able to tell that the way they're perceiving things through their eyes is a little bit different day to day. But sometimes because it is a chronic condition, you can see significant difference between a healthy individual and patient with early stage dementia. And so that's sort of what we'll get into in the next slides. So based on these medical observations in speech and eye tracking that occur before symptoms in Alzheimer's, other disciplines wanted to see if they could apply their knowledge to identify these changes early on. And in particular, computer scientists specializing in artificial intelligence began exploring speech and eye tracking data. So some of you are probably wondering what exactly is artificial intelligence. And so artificial intelligence is just really a fancy word to describe how to use computers in a way that can simulate human behavior to help us find patterns and solve complex problems. And so machine learning itself, as you can see in that little smaller bubble, is a subset of artificial intelligence that takes in data, learns from it, and gives out a classification accurate result. So there's a lot more depth to the field than this, but for the purposes of our study, the CANARY study, the problem that we are trying to solve is identifying individuals who are at risk for neurodegeneration before the clinical symptoms start to appear in a scalable and cost-effective way. So machine learning is taking the speech and eye tracking data we collect from our participants and learning from it to identify what speech and eye gaze patterns characterize patients who are at risk for neurodegeneration and set them apart from healthy individuals.
So what does this process look like? So raw data is inputted into the machine learning algorithm, and then it is split into training and testing sets. Part of the data is used to train and build the machine learning model, and part of the data is used to test the model for accuracy. The data is then output with a classification label in our study, either as a patient or as a healthy individual. This process is then repeated to continue to teach the model and improve accuracy in identifying speech and eye tracking patterns that distinguish patients with neurodegenerative disease. So previous research in machine learning and natural language processing has examined the speech signals of patients with Alzheimer's disease. However, many of these studies used small sample sizes or small groups of people to analyze their speech characteristics, with very few of those individuals in early stage disease. They also looked at single speech tasks in isolation, so reading a paragraph or describing a picture, but did not look at multiple speech tasks.
Researchers also began investigating recording eye movements during simple cognitive tasks, such as reading. And so they trained machine learning algorithms to classify between patients and controls. And so controls would be people that are healthy and they are screened so that they aren't presenting any sort of cognitive impairments, whereas the patients are the ones with some sort of diagnosis or subjective memory complaint about cognitive impairments. And so essentially some characteristics of eye behaviors can be identified by the machine learning algorithm and used to distinguish between healthy individuals or the control population and patients with Alzheimer's disease. And so we'll go over a couple examples of some of these eye behaviors when we introduce our study task and their results.
So while eye movements and language have been looked at individually as an input for machine learning algorithms over the past 10 to 20 years, the combination of speech and eye movements has been poorly investigated when analyzing them together. So our big question is, can a machine learning algorithm built on eye tracking and language data be used to automatically differentiate memory clinic patients from healthy individuals on multiple speech tasks?
And so our current algorithms are training to differentiate and classify healthy individuals from patients with subjective memory complaints, mild cognitive impairment, and early stage Alzheimer's disease. To classify our data, we feed the algorithm speech and eye tracking data collected from participants completing 4 easy tasks, including fixation on a point on the screen for calibration, reading a paragraph, describing a picture, and describing a memory. And so I know this is a lot to look at right now, but pretty much what we have listed in this table are each task individually labeled with our artificial intelligence's prediction accuracy of patients versus healthy individuals. And these are the results for each task from our baseline data during a participant's first visit. But we are still analyzing our follow-up data and still recruiting and enrolling participants to reach our full sample size. So these are not yet the final results. And so these numbers convey AUC, or area under the receiver operating characteristic curve. The AUC is just a technical term that describes a measurement of how much a model is capable of distinguishing between classes. And in our case, it implies a degree of success in identifying differences between healthy control patients and patients from the memory clinic. So basically it tells us how good it is at telling which person is a healthy individual, meaning someone displaying no symptoms whatsoever and have passed our screening criteria, versus someone who has been recruited from the Alzheimer's clinic. In a single task alone, our algorithm was able to identify patients based on their speech and gaze features with a highest accuracy of 80% for any single task. And when we combined features from all the tasks together, so the 4 tasks that I briefly mentioned earlier, we were able to achieve a highest classification accuracy of 83%. So our AUC of 0.83 basically indicates that the data from our assessment contains valuable information for predicting Alzheimer's disease. So what do those classifications really mean? These videos right here are of our first task, the pupil calibration task, showing the eye movements of a patient in our study compared to a healthy volunteer in our study. And so the red dots indicate fixation points, or when the eye focuses on a single point. The red dot grows as the participant fixates on a specific point. So the larger the circle is, the longer the participant has stared in one spot. And although it's sort of a brief 10-second task, our algorithm was able to distinguish patients from healthy controls with a 71% accuracy just from looking at a cross on a slide. So patients showed more variation in their eye movements to and from the cross and had more eye movements overall in this task. And so once again, just to reiterate, the patients are the ones presenting or in early stages of cognitive impairment. And so they fixated on the cross for a shorter period of time and showed more refixations to it during this task. So this here is an example of our picture description task. On the left-hand side is an example of someone who has a clinical diagnosis of Alzheimer's, while on the right-hand side is a healthy volunteer in our study. So each of the red dots represents a moment where the eye fixated on a part of the picture, and the red lines show the eye movements between areas of the picture. And as you can see, there are differences in the pattern of eye movements between healthy volunteers and those with Alzheimer's disease. So patients looked at and spoke more about the window and exterior or non-crucial information in the photo compared to healthy controls, and they had a less organized approach to looking at the photo while speaking about it. So these videos here, if you pay attention, they show a heat map of a patient versus a healthy control completing the reading task. So the green indicates where the participant is looking as they are reading the text, and the yellow and reddish colors show that the participant is rereading or fixating for a longer period of time on a specific word. And as you can see in the video, patients had more refixations on previous words they had read, and they were less systematic in their reading. And then also you can see how much quicker the healthy volunteer is finishing the text if you compare the right video versus the left video. Also, the healthy volunteer has a lot less refixations or a lot less yellow/reddish parts on the heat map because they're not sort of looking back at words that they've already read, and they're focusing on the words that they're reading at their steady rate. So this is the memory task, and as you can see, there's no visual stimulus provided. So participants are just looking at a blank screen for this task. For the memory task, there was no visual stimulus. And so while they were staring at this blank screen, they were just recalling a positive memory. And we found that the eye patterns recorded during this task were not predictive of a patient or healthy control. And they were essentially random. So where people were looking while looking at this blank screen didn't really tell us, or it didn't give us enough evidence to distinguish between a healthy control and a patient from the clinic. But the acoustic characteristics of the speech signals that we were recording, such as pausing and speed of talking while they were describing their positive memory, were highly predictive and identified patients from healthy controls with a 77% accuracy. So I just saw a quick question, is the language component specific for English? Yes, it is. Our study is conducted only in English, and so that is a requirement for enrolling in our study, being fluent in English.
So if you are interested in participating in this research project, the commitment involves a screening telephone call to ensure you fit the eligibility criteria for our study. And then we would ask you to complete a brief 10-minute speech and eye gaze assessment at our office at UBC Hospital. During this time, our non-invasive eye tracker will be recording your eyes while your speech is recorded. Afterwards, we would ask you some demographic and medical questions and complete a brief cognitive assessment. Typically, the baseline appointment takes about an hour in total. Since we are also looking to classify disease stages over time, we ask participants to complete follow-up assessments every 6 months for 2 years. This will allow us to track changes in speech and eye gaze patterns at different stages of the disease progression for our patient population. And for our healthy volunteers, as mentioned, because we do administer a brief cognitive assessment that is widely used in clinical settings, this will allow you to have a regular reassessment of your cognitive abilities. And if a healthy volunteer's performance on any of our study assessments indicated a cognitive impairment, our study doctor would review your file and make a referral to your family doctor to have any additional assessments as necessary. Any other costs associated with participating in the study, such as parking or transit-related expenses, will be covered by us if you do come into UBC Hospital.
So anyone over 50 years old, fluent in English, and able to provide informed consent is invited to participate in our study. We do have a few exclusion criteria, but we can look at them on a case-by-case basis if you are interested in participating. We are specifically looking for individuals with a clinical diagnosis of subjective memory complaints, cognitive impairment, or mild to moderate Alzheimer's disease, as well as healthy volunteers for our study. So people that have met our screening criteria. So I see a couple chat questions about, so for example, will pre-existing eye disease affect the results of the test? Yes, but it really depends on the nature of the eye disease. And so that's part of our screening process when we're enrolling patients. So say you had something like lazy eye, because our eye tracker is recording where your eyes are looking. If your eye is sort of drifting off to the side, it can really affect the results. So things could be offset and our eye tracker wouldn't be able to accurately tell what you're looking at. Things like cataracts or glaucoma, if they're resolved and aren't really affecting your ability to see or read nowadays. Generally, those people are okay to participate in our study. It just depends on the severity. And so once again, that case-by-case basis for screening our individuals and participants would be used. And then would someone with cognitive difficulties from something like post-concussion syndrome qualify for your study? So once again, I know it's a little bit vague on this on the slide because there's limited space, but we sort of address it when we say previous head injury. So once again, it depends on the severity of the head injury or the traumatic brain injury, and also to what extent it's affecting your cognition. So generally, when we say previous head injury, that means hospitalized for an extensive period of time at a hospital because of the head injury itself. And so it also depends how long ago the traumatic brain injury was. And so just to reiterate, the case-by-case basis, if you are interested in participating, would be used.
So yeah, we really encourage anyone who is interested to email us at our canary.study@ubc.ca email address. It has been put into the chat. And then we would go over any sort of questions about inclusion or exclusion criteria or pre-existing medical conditions with you on our screening telephone call. In terms of if you are not on the mainland and can't attend UBC for the first session, we do our follow-ups remotely. However, because we are trying to get everyone with our accurate eye tracker for their baseline data, we do need everyone to come into UBC just for that first visit. And then if our remote ones would prefer to be conducted remotely, we can do that for the rest of the follow-up visit.
So I can see that Chris over here has said that he's in Victoria and can't easily get to UBC for the first appointment. So generally we do want the first appointment to be in person, just so that we can take an accurate baseline and sort of see where the participant is when they first start. So say for some reason they do end up having some cognitive impairments down the line, we could get an accurate reading at the beginning so that we know that, you know, maybe it's not just a recording of our data that messed up. And that's the reason why it's appearing that the quality of their cognition has decreased. So we do have, once again, as Caitlin said earlier, the remote follow-ups, but we still highly encourage at least one follow-up per year in person. And that does not include the first follow-up, which has to be in person for our study. And is this study focused on participants from the Lower Mainland? Well, as far as accessibility goes, I guess, but we're not trying to exclude anyone else if they're enthusiastic about participating in our study. So if you can make it out, we would encourage you to come. But it just happens to be that a lot of our participants are from the mainland because it's easier to get to UBC here.
And in terms of ferry costs, I see a question in the chat for that. We don't cover ferry costs just because this is a voluntary participation in research and not an actual required medical appointment. But for you to come to UBC and park and bring your vehicle over, we would cover that cost.
Does Parkinson's exclude you? Actually, we're looking to enroll participants with Parkinson's probably in the future. So we would have a conversation about this if you were still interested, because as you can imagine, our technology is not just limited to dementia as a neurodegenerative condition, but sort of hopefully we can use it to see if we can distinguish people, healthy people versus people with Parkinson's just based off of their eye movements or their speech. If people are under suspicion of having Parkinson's. And so we're trying to see if maybe early detection can lead to research down the line that would develop some sort of treatment plans earlier on, or it could serve as some adjunct diagnostic tool for people that are treating patients with dementia or suspicion of dementia.
And for the question in the chat about early onset at 50, but not showing any symptoms yet, definitely, we would love to hear from you. Please send an email inquiry to the canary.study@ubc.ca, and then we will reach out to you individually via the phone. I also wanted to mention here our website. If you are ineligible to participate or you're just interested in learning more about our research and reading some of our scientific publications, they are all found on our website at canarycognition.med.ubc.ca. Please feel free to visit that. And then to just wrap up our presentation here, any other questions, experiences you would like to share, comment, anything with that?
Is there anything that you didn't understand or want further clarification on? Or maybe you just want to share about your experiences living with dementia or as a caregiver for someone diagnosed with it. And also now would be a good time to direct comments to us about possibly improving our presentation in the future.
We do have a feedback survey. I believe it will be sent in the chat as well. We'll take the information from this on how we can improve our presentations in the future and clarify anything that was unclear. Thank you very much for having us. We appreciate having this platform to talk about our research and really hope to meet a lot of you in the future.
And just real quickly, so for Chris's comment about the lab at UVic that does use eye tracker technology. So ours is specifically the Tobii Pro professional eye tracker. And so we haven't been in contact with him as far as I know about contributing to our research, because for the most part, participants from the island do make it out to our first appointment in person, and then we offer the remote assessments for those individuals. So there's not like a huge demand for having an eye tracker on the island per se, but maybe there's a chance that down the line we could talk to him about hosting the island participants to see if him and sort of maybe one or two research teams can give us accurate data.
Sorry, Caitlin. There is a question. I don't think it was addressed, and I just wanted to bring it out. There is a question asking if there is research that identifies a specific area where amyloid plaques are concentrated, and if there is specific cognitive loss associated with this part of the brain.
So, as far as I'm aware, a lot of the plaques are very wide distributed in Alzheimer's disease patients. We do see specific areas that are affecting specific cognitive impairments. So, like I mentioned, with the speech impairments as a result of these plaques building up in Broca's area and the perisylvian region. I believe more frontal lobe plaques can deal with more attentional difficulties and other cognitive problems, but there hasn't been a ton of research identifying this specific region with this amount of plaque leads to this specific outcome. I think, again, more advances with neuroimaging might allow us to draw that conclusion, but I don't believe we're there quite yet.
So someone commented, my parents are both suffering from dementia and both experience accelerated deterioration during COVID isolation. So going back to that sort of point about social activity and social interaction, I do believe that that is a risk factor and it plays a role in slowing the rate of cognitive decline. Of course, once again, to reiterate, there is the whole holistic approach. You do need to tackle multiple risk factors at once to really have a significant impact. So hopefully your parents are, they have good exercise habits and eating habits. And so if they were allowed, according to health guidelines, to have more social interaction and talk to people, it would slow their rate of cognitive decline.
I've also found from just hearing from a lot of our participants in the study that are a part of this BC Brain Wellness program that a lot of their regular webinars or their online physical activity classes have allowed them to really still interact with people socially and create a bigger network with these people. So it's been very beneficial for them throughout this COVID isolation pandemic. And I would encourage everyone to check out all of the other programs and webinars that the BC Brain Wellness puts on.
And then a question from Ruth. If someone has been diagnosed with mild cognitive impairment, would they be appropriate for your study? Yes. We are still looking for people with subjective memory complaints, mild cognitive impairment, and a diagnosis of early or moderate Alzheimer's disease. These people will just enroll as a part of our patient population. But we still do invite people who are healthy and elderly to participate as part of the healthy control population.
And for the question, I believe that my husband is experiencing dementia. Any advice? We would recommend to reach out to your general practitioner, or there is the UBC Alzheimer's clinic here that you could reach out and get an appointment. I think getting assessed and understanding your disease progression earlier can help both you, your husband, and kind of help plan your experience with dementia.
And thank you very much. And I see that Cheyenne entered our link to our current programs in the chat. We do have exercise programs and creative programs and lots of a wide variety of programs. So if you are interested, please do feel free to check the link in the chat. If there are any more questions, please do feel free to send them in the chat. We do have a few more minutes left to answer any questions that you might have.
Mm-hmm. And then could you possibly drop the link to the feedback survey once again, just in case anyone didn't catch it earlier?
Yes, absolutely. And to address the question in the chat, yes, this session was recorded and it will be available sometime on our website.
And for the question about is the study in the domain of Dr. Rob Armstrong, we are not currently working with Dr. Rob Armstrong. We are primarily under Dr. Thalia Field. She is a stroke neurologist at the Vancouver Stroke Program, as well as Dr. Robin Chung and Dr. Nygaard at the UBC Alzheimer's Clinic.
And then, of course, we have a number of co-investigators that are heading our computer science aspect, so that artificial intelligence and machine learning. Just to drop a couple names, Dr. CANARY, and there's also many others in our computer science team that are not here today, but I'm sure they could give you an extremely extensive explanation of the sort of machine learning aspect. If you were interested in learning about how specifically our AI is working to classify these diseases versus healthy individuals. I'm pretty sure you can find a lot of this information or where to contact them on our website.
Yes, so a lot of our more scientific research papers break down our machine learning algorithms and how they really work to identify these specific eye tracking and speech features. We also, in our breakdown per task, talked about just a few that were predictive of patients versus healthy individuals, but there is also lots more in these papers. So feel free to check that out. And if you did have any questions, you could also email our study address at canary.ubc.ca, and we can help you answer any questions that you may have.
If there are no more questions, or if there still are any lingering questions, please do feel free to send them in the chat. But otherwise, I would just like to thank you so much, Caitlin and Rhiannon, for your wonderful presentation on dementia and risk factors and artificial intelligence and the amazing study that you have going on. I'm sure that we all learned very much. And I would also like to thank you all for joining us for our very first session of the research seminar series. Once again, this series is happening on a monthly basis. Our next session is happening on October 20th. So that session will be up for registration in quite soon. So please do keep an eye out for the next session, and we hope to see you there.